Good evening, everyone. Today we welcome you all on the platform of Spiritual Doctors for Holistic Health. With me is Dr. Saurav Ranjan and Dr. Chandana. Dr. Saurav.
आज हमारे साथ यूएस से डॉक्टर कान जुड़ चुके हैं। अभी हम उनको माइक थोड़ी देर में उनको देंगे। पर्सनली मैंने देखा जो पूरी सोसाइटी में लोगों के भीतर जो डर होता है हार्ट डिजीज का, कैंसर का, डायबिटीज का, तो डायबिटीज पे तो बहुत लोग काम कर रहे हैं, वो बातें सामने लानी है। और हार्ट डिजीज और ऑन्कोलॉजिस्ट, कैंसर स्पेशलिस्ट, ये दो व्यक्तिगत रूप से मैं चाहता हूं कि ज़्यादा जो भी थोड़े होलिस्टिक वे में काम कर रहे हैं उनको हम मास के सामने लाएं, उनके कंसेप्ट्स को। लोगों के भीतर से डर निकलना चाहिए। एज ए मेडिटेटर, एज ए स्पिरिचुअल एनर्जी हीलर, मुझे तो कोई डर नहीं लगता। मैं तो विश्वरूप और विम हॉफ की तरह कोरोना के मरीज के बीच में भी बिना मास्क भी जाऊंगा तो मुझे इन्फेक्शन नहीं हो सकता, ये ऐसा कॉन्फिडेंस मेरे पास है। वैसे मैं गया नहीं हूँ, लॉकडाउन में मैं अपने कमरे में ही हूँ और बिल्कुल अपनी बिल्डिंग से बाहर नहीं निकलता।
ये फॉलो करना बहुत जरूरी है डॉक्टर सौरभ, बिकॉज देयर इज समथिंग दैट व्हिच इज कमिंग अप and you are right that there are treatment, there is immunity from certain diseases which can be developed by plant based diet and holistic health and taking care proper lifestyles also. तो हम लोग इन सब चीजों से मुक्त हो सकते हैं, इन चीजों को प्रिवेंट कर सकते हैं। जैसे कि हमारा आज का टॉपिक है प्रिवेंट हार्ट डिजीजेस। हार्ट डिजीज को कैसे प्रिवेंट किया जाए। और डॉक्टर जॉन कॉल, जो डॉक्टर जॉन कान है, वो खुद भी मर उनके हार्ट में थी और खुद को उन्होंने ट्रीट किया। ये बहुत बड़ी बात है। तो दो तरह के लोग होते हैं, एक होते हैं जो नॉलेज रखते हैं और अपने पेशेंट के ऊपर ट्राई ऑन करते हैं और वो रिजल्ट्स को शेयर करते हैं, और कुछ लोग ऐसे होते हैं वो खुद के ऊपर पहले यूज करते हैं, वो उसके रिजल्ट पहले प्रोड्यूस करते हैं, फिर वो बाकी लोगों के साथ शेयर करते हैं। एंड टुडे वी आर वेरी लकी दैट डॉक्टर जॉन कान इज विद अस एंड ही इज ए प्रैक्टिकल एग्जांपल, जिन्होंने खुद का जो हार्ट डिजीज थी उसको रिवर्स किया और लाखों और पेशेंट्स की जो हार्ट डिजीज है उसको रिवर्स कर रहे हैं, और जो रिजल्ट्स हम बात करते हैं वो प्रोड्यूस कर रहे हैं वहाँ।
यस, और उनकी मैंने कई सारे यूट्यूब वीडियोस देखे, उनकी बुक्स पढ़ी, और सिंप्लिसिटी ऑफ दिस मैन, आई अप्रोच्ड हिम ऑन ट्विटर, लिंक्डइन, एंड ही रेडिली एक्सेप्टेड। तो स्पिरिचुअलिटी को डॉक्टर संदीप मैं ऐसा समझता हूँ, मानता हूँ, इनडायरेक्ट इंडिकेशन उसका जो होता है वो सिंप्लिसिटी होता है। जो पर्सन जितना सिंपल है, जितना हम्बल है, आराम से बात करना, कोई ईगो नहीं, दैट इनडायरेक्ट इंडिकेटर ऑफ स्पिरिचुअलिटी। मैं तो खैर इनसे पहली बार ही जुड़ रहा हूँ, मैं कोई ज़्यादा लंबे समय से इनको नहीं जानता हूँ, मतलब हाँ कुछ महीनों से जानता हूँ ऑनलाइन ही, बट हमारे पास आ रहे हैं।
On this channel, Spiritual Doctor for Holistic Health, today with us is Dr. John Kahn. Dr. John Kahn is a plant-based cardiologist, clinical professor of medicine cardiology at One State University of Medicine at Detroit. He is a prolific writer, speaker, author of 4 books. His famous book is Whole Heart Solution, and he's contributed to the Huffington Post. एंड हमारे पहला सेशन जो था डॉक्टर सौरभ, उसमें आपको याद होगा हमारे पास डॉक्टर खादर बली आए थे।
yes.
और अभी हमारे साथ में डॉक्टर जॉन कान जुड़े हुए हैं, जो कि प्लांट बेस्ड मेडिसिन, प्लांट बेस्ड न्यूट्रिशन, प्लांट बेस्ड जो डिजीज रिवर्सल के ऊपर काम करते हैं, और पिछले 41 ईयर से ही इज डाइट।
और वो वेन स्टेट मेडिकल यूनिवर्सिटी में प्रोफेसर भी हैं, तो इनके पास एजुकेशन का बहुत एक्टिव इंटरेस्ट है। और सोशल मीडिया पे भी ये बहुत तरह जो न्यूज़ होते हैं, मैं ट्विटर पे और लिंक्डइन पे इनसे काफ़ी जुड़ा हुआ हूँ, तो इनकी एक्टिविज्म वाले अप्रोच को भी मैं थोड़ा देखता हूँ कि जो अलग अलग रिसर्च स्टडीज आते हैं जिसमें प्लांट डाइट के बारे में कुछ है, तो उनको वो एक्टिवली वो प्रमोट करते रहते हैं।
तो डॉक्टर सौरभ 5 बजने वाले हैं और वी शुड वेलकम डॉक्टर जॉन कॉन। डॉक्टर जॉन, वेलकम टू स्पिरिचुअल डॉक्टर ऑफ होलिस्टिक हेल्थ सर।
Good
Hello.
afternoon. Good afternoon. It's good morning here, and thank
Good
you
morning.
very much.
Here in
Thank you
India,
for
it's
inviting
5
me.
p.m., sir.
I'm wearing a shirt that says "Make America Healthy Again." So,
great, sir.
but thank you for the invite, and very honored to join your group and beam out on Facebook all over the world. It's very exciting. It's good that we can connect and commune and learn from each other. So let me go back to Zoom for a second and do share screen.
Dr. Kahn.
Yes. Yes.
Before starting the formal presentation, I want to ask some informal question.
Sure.
By what time you wake up in the morning usually?
6 o'clock, 6 a.m.
6 a.m.
I don't have it on now. I wear a little ring called Aura, O-U-R-A ring, and it monitors your REM sleep, deep sleep, and all. It's nice, it's accurate. So I always get about 7.5 hours of sleep.
Oh, wow, great.
Great,
thank
sir.
you.
And in the beginning, sir, thank you very much for taking out time from your busy schedule for us. Over to you, sir.
Well, thank you very much. Let's see how this goes. You can see the screen?
Yes, sir.
PDR.
Wonderful. And let me just hit one more button. Wonderful. So we're going to talk a little bit about preventing, detecting, and reversing heart disease in a way that is a little different than I learned in medical school and training years ago, and has proven to be very helpful with my patients, my own health, I think. And certainly what I learned and what is taught is when we're children, we are born with perfectly clean arteries. There's 50,000 miles, maybe 20,000 kilometers of arteries through the body. They're perfectly clean, undamaged, but even by the time we're teenagers, playing after school, we start to develop some signs that humans are very prone to develop disease of their arteries or atherosclerosis. And by the time we're in our 30s and 40s, it becomes very common to even have occasionally clinically important lesions or plaques, but certainly by our 50s, 60s, and 70s, it advances to become the #1 killer of men and women throughout the world. And I'm sure the statistic is very close in India. If it's not #1, it's very close to #1 killer of men and women throughout India.
To #1. Very close to #1 in India also.
Yeah. This slide is of very interest historically to me. And it makes the point again, this is a disease that starts early in life and progresses so slowly and silently, but we can prevent it and we can detect it. The bars that are the tallest all the way over to the left are soldiers from the United States that fought in the Korean War. So that would be in the 1950s. And these were unfortunately soldiers that died and had autopsies, but they didn't die of heart attacks. They died of gunshots and explosions. And the tall bar shows that 75% of them, despite being 21 years old, 24 years old, 25 years old, had plaque in their heart arteries. And the smaller bar shows about 18 to 20%. They were actually already fairly severe lesions in their arteries. Now, the middle group is the Vietnam War in the 1960s, and all the way to the right is the Iraqi conflict that the United States was involved with about 15 years ago. And it's good news that the amount of atherosclerosis seems to be decreasing, even in young people. It may be there's less smokers in young people, which is the statistics. It may be there's a bit less what are called trans fats in the diet, which is a good thing that's happened. And maybe there's better blood pressure and cholesterol medicine for some young people. But we've got a long way to go because this disease starts and affects almost all of us and at a very young age. Again, as I said, in the United States now for over 100 years, heart disease has been the #1 cause of death, followed by cancer, followed by lung disease like emphysema. And we have not made a significant, advance on causing heart disease to become a rare cause of death. It's simply not the case. And sadly, very often it's a cause of death in people that are in their 40s, 50s, 60s, and 70s. But I don't want it to happen in people in their 80s or 90s either. One of the major breakthroughs in this idea of what causes us to die was this analysis in around 2000, where if you look in the green bars, once again, we see what causes death, at least in the United States: heart disease, cancer, stroke, and chronic lung disease like emphysema. But what these researchers looked at in the orange bars was what was the actual cause of death. What causes heart disease, cancer, and lung disease? And by far, 85% of all these deaths were due to 3 findings. Do you smoke cigarettes or not? Do you eat a poor quality, meat-heavy, fat-heavy diet or not? And do you have physical activity in your life, or are you sedentary? And this suggested we might be able to control up to 85% of heart cancer and lung deaths by public education about don't smoke, eat fruits and vegetables, and be physically active. And we've been at that all over the world, of course, for decades, trying to educate people. But it makes the point that it is lifestyle more than genetics, far more than genetics, that seems to determine ultimately our health. And we all know this: when we reach for a cigarette or reach for fried food, it's probably not going to move our health forward. And when we eat, a fresh, clean meal, a big, large salad, and we go out for a walk, we are advancing our health and preventing disease. So this is a classic slide that makes the point, in the medical system, where we're very good at mopping the floor. The example would be people have a heart attack. And I trained for years and practiced for years treating their heart attack with stents and angioplasty balloons. It was wonderful emergency care of a very sick patient. But if you don't turn off the faucet, we're going to just keep doing this and doing this and doing this. And the faucet is smoking, and the faucet is inactivity, and the faucet is poor quality and processed diets. And that's why we have to focus on the root cause, the real fundamental cause of these, killing diseases and diseases that rob us of quality of life. So it has been estimated from a number of studies that 85% of heart disease, 90% of type 2 or adult diabetes, and 60%, some would say even more, of cancer is largely related to our choice of food, our choice of fitness, and our choice of smoking or not smoking. There are factors beyond that. More and more we're learning air pollution is a major factor, water quality, toxins in the environment, genetics, of course. Sleep medicine is becoming a big, important role. And you ask me what time I wake up, so you're attuned into good sleep. Chronic infections can be part of this, but it still boils down that the biggest part are easily controllable factors to avoid, the diseases that cost hundreds of billions of dollars to treat, but more importantly, cause so much suffering. So for example, if you look at the very bottom, there's 2 studies that were published about 6 years ago. In total, about 40,000 people that were very healthy at the beginning of the study, but they followed them up for about 15 years and identified who during those 15 years had a heart attack, because heart attacks are very common. And they identified a group of people that were almost free of heart attacks in follow-up. And these were the 5 habits in a multivariate analysis statistics that you can do, that anybody can do, to avoid a heart attack. Don't smoke, walk every day, eat 5 or more servings of fruits and vegetables every day, which is far more than the average person eats, sadly. I just had a strawberry blueberry smoothie. I think I had 4 servings of fruits and vegetables already this morning. Sleep 7 hours at night. That's interesting. That's nothing we were ever taught in medical school, but people that pride themselves or just can't sleep more than 3 or 4 hours a night, apologize again, are more prone to developing a number of diseases. And unfortunately, a lot of people that have to rotate shifts, like police officers, nurses, doctors in the emergency room, and factory workers that rotate shifts, so their sleep is very messed up, are also at risk. And finally, and surprisingly, I never encourage anybody to drink alcohol, but in these studies, a few drinks a week was preventive, was protective, but that's a small number of drinks. That's not encouraging you to have too big a party tonight. So let's talk a little bit about detection. I showed you some data that this disease starts very early in life, in teenage years, and progresses. And this brilliant English doctor who lived in the 1600s, so about 400 years ago, Thomas Sydenham, MD, he wrote a textbook of medicine that was used across Europe for about 200 years, said a man is as old as his arteries. And I would say now we have to be a little bit more careful in our use. So a person is as old as his arteries. And if you knew that by good fortune, maybe good planning, your arteries were young and you were 45 years old and you've not developed any detectable atherosclerosis, you'd be in very good shape and you don't necessarily need prescription medication and your outlook is very rosy. But if you were 45 years old and you learned that you did have older arteries, and there actually is a language of that, we call it vascular age or arterial age. You can be 45 years old and there are tests you can have that tell you your arteries are like a 65-year-old man. Well, that really shakes people up quite a bit and gets them to look at their lifestyle. And then we have to do some evaluation of their laboratory studies and their fitness. But can we possibly identify really in a large number of people how old your arteries are so we can guide people and personalize their treatment? And one of the challenges is this statement: if coronary artery disease was attacking your face rather than your heart, you'd do something about it. The point being, it's a silent disease. It's a silent disease inside our body. We don't feel heart disease for the years and years it's developing. We don't notice it. Doctors can't see it. So we almost act like heart disease doesn't exist. If it was a rash on our face, we'd go right to the doctor and beg for treatment. So how well do we do at early detection? No problem. Early detection of this killer. And I have America's #1 killer, but again, I would believe it's a very, very important cause of death. Of course, South Asians do have a very high incidence of heart disease. And this example is, would you ever guess, looking at Winston Churchill, a historical figure you know, overweight, not very active, always with a cigar in his mouth, would you ever predict that he would live to age 91? And would a doctor ever look at this man who's running, who is one of the more famous athletes in the United States in the 1970s? He started the whole marathon fitness craze. Thin, athletic, non-smoker. Would you ever believe he would drop dead of a heart attack at age 53? So when we just look at people externally, we're not really very good in the medical world at identifying who has aging arteries, as Dr. Sydenham of England said. So we have to go a little further than that, because some people are walking around. This is called a heart angiogram or a coronary angiogram of the left coronary artery. And the black arrow is showing where there is a severe narrowing of the front artery to the heart, the left anterior descending artery. There's also multiple other areas of atherosclerosis here. But people can be asymptomatic. No shortness of breath, no angina pectoris. People can have normal electrocardiograms, normal blood pressure, and still have this kind of life-threatening situation. So how do we try not to miss cases to detect this disease that we know is present in so many? So we do know, as I showed you in that initial picture, that we start with healthy, clean arteries in childhood. We develop these going from top to bottom, little tiny abnormalities, almost undetectable fatty streaks. But in the middle, it says intermediate lesion. These fatty streaks get more cellular white blood cells and macrophages. They also get calcified. We start to accumulate calcium in these plaques. Anywhere there's damage, there usually is some deposition of calcium. So long before we get to the very bottom where we have like a volcano, a atherosclerotic lesion that's opened up and is prone to clot to cause a stroke or a heart attack, we have a long period of time, and we have a period of time that these arteries get calcified, which is actually helpful. But before we go to how we find calcified heart arteries early, how do we detect them so we can prevent them getting worse? There are a few simpler clues that work some of the time. If you lose hair on top of your head early in life, in your 20s or 30s, there may be some imbalance of your antioxidants, and it may represent an imbalance that's also affecting your heart arteries. If you lose hair early around your temples, the same. Certainly, if there are yellow fatty deposits around the eyelid, there may be a genetic cholesterol disorder and a cholesterol that's extremely high, and doctors can identify that. But maybe the most interesting is this one called the earlobe crease that is still not very well known, even though it's got 50 years of tradition and quite a bit of science. So this handsome man you might recognize is Steven Spielberg, the movie producer or director of so many movies like E.T. and other Star Wars. But if you look where the red arrow is, you can see that in his earlobe, he doesn't know he's volunteering for this picture, but I pulled him off the internet. He has a deep crease in his earlobe, and we're not born with those deep creases. And 50 years ago, a very observant doctor in New York City noticed that he thought his heart patients had this earlobe crease where his patients that were free of heart disease did not. And he published that paper in the New England Journal of Medicine. And it turns out subsequently, in the last decade, using advanced heart imaging, it's about 70% accurate to notice that somebody has a deep earlobe crease and that they also are developing blockages in their heart arteries. 70% accurate. That's about as accurate as a treadmill test the doctors order in the hospital, an exercise treadmill test. It's by no means 100% accurate. I've seen many people with the crease that prove not to have heart disease. There is a theory it has to do with collagen. Your earlobe is manufactured of collagen. Your arteries are made of collagen. We need to eat a healthy diet, very rich in vitamin C to make enough collagen. And of course, vitamin C, we're not getting from meat or cheese or eggs. We're getting vitamin C from leafy greens and peppers and apples and oranges. And it may be that a poor diet not only shows up internally in the arteries, but a poor diet gives us a clue in the earlobe. Another important clue to identify heart disease before it causes a heart attack or death is in men, erectile dysfunction. And it's felt that erectile dysfunction is a warning sign of clogged arteries. Many doctors will just give a man a prescription for a drug for erectile dysfunction like Viagra, but they really should ask the question, what's the blood pressure? What's the cholesterol? What's the blood sugar? Maybe you need more testing to see why this is a problem. It's estimated that by age 50, 50% of men are suffering from erectile dysfunction, and by age 60, it's 60%. So it's a very common reason for a doctor visit, but we miss the opportunity to identify heart disease early. The term canary in the coal mine, you might know, you might not, but miners in the days of old, 100 years ago, used to take a bird in a cage into the coal mine. And if the carbon monoxide levels were going up, the bird would stop singing and would be at risk of dying. And it would be an early warning sign that the miners were at risk of death also, and they would leave the mine. And that's the reference that erectile dysfunction is an early warning for heart disease. What about advanced lab testing, blood testing? How do we identify who is at risk for this very common problem of clogging of arteries? Well, it's very important to check cholesterol where it says LDL, that's the cholesterol, LDL, low density lipoprotein level. But there's a lot of overlap. People with very high cholesterol levels are at more risk, but a lot of people who do have a heart attack or need a bypass operation, their LDL cholesterol level overlaps with a lot of other people, and it's hard to rely on that number alone. Of course, we also rely on the HDL cholesterol, the triglyceride level, the blood sugar level, and others. This is a gruesome picture. It's supposed to be an artery in red, full of plaque being the yellow obstruction. And each of these knives is another reason beyond LDL cholesterol that we can get atherosclerosis. And we can measure most of these in blood work. We can measure the blood glucose level, the blood insulin level, inflammation called C-reactive protein. We can measure hormone levels. We can measure fibrinogen and homocysteine, and of course your blood pressure. So you have to look at the whole picture. I recently published a book earlier this year. Actually, now it's my 6th book, called Lipoprotein(a), the Heart's Quiet Killer. And this, if you're unfamiliar, is a form of cholesterol. It's inherited, it's genetic. It does not depend on your diet. It does not depend on smoking or fitness. And 1 out of every 4 persons, 1 out of every 4 inherit this from one or both parents. So 75% of people, if they have a simple blood test, the blood test is called Lipoprotein(a), available all over the world, inexpensive. 3 out of 4 people will show none of this in their blood, but 1 out of 4 will have a modest or a high level based on genetics. And you have that from birth, so it's present throughout your life. It never shows up on a routine cholesterol panel. It takes a special blood test, but it's widely available. And we know that lipoprotein(a) does 3 things. It has an LDL cholesterol in it, so it carries a lot of cholesterol to get into arteries. It has a special large tail that causes inflammation, and it has a special bridge that causes blood clotting. So it can cause plaque, inflammation, and blood clotting to lead to heart attack, stroke, and heart valve disease, a very serious disorder called aortic stenosis. We're waiting for a therapy for this if a person's identified to have inherited it. But think about it, in India, that's hundreds of millions of people have lipoprotein(a). And sometimes they've had a heart attack or a stroke, and their doctor says, we don't know why you had one. Well, you start to check lipoprotein(a), you'll figure out a lot of reasons why people have heart attacks and strokes that weren't known before. There isn't a clear-cut therapy at this point. There is a vitamin that's very inexpensive called niacin that lowers cholesterol and lowers lipoprotein(a). But there aren't that many studies on using niacin to look at 10-year or 15-year outcome. And there is a drug being developed by a pharmaceutical company called Novartis that looks very promising, but it's a number of years away from going through the testing that will allow it to be used more liberally. But if you have patients that have a family history of heart disease, or if you're concerned about your own health, you might add a few blood tests like lipoprotein(a) to your blood panel. But the bottom line on detecting heart disease early is this statement: the best test for the prediction of the risk of atherosclerosis is the demonstration of atherosclerosis. And that means we can look at arteries to see if your lifestyle and genetics are preventing heart disease, or if your lifestyle and genetics have resulted in silent atherosclerosis. And it makes a big difference in how you might be treated. So if you look over on the left, screening for atherosclerosis, we've talked about high LDL, HDL, blood pressure, diabetes, smoking. There's lipoprotein(a). But if you look over on the right, there are ways using ultrasound and CT CAT scans to actually look at arteries directly. So this is a very important picture. And if you look to the left, when there's only a small amount of atherosclerosis in an artery, maybe a 20-year-old, early in the game. There's good blood flow, there's no symptoms. If you did a stress test, it would be normal. If you did a kind of heart CT scan, it would be normal. But if you go over to the moderate disease, I think we should be finding heart disease early so we can teach people how to prevent it. Only a small little bit of obstruction, you're not going to have symptoms and you're not going to flunk a stress test. But if you do, it's called a calcium CT scan of the heart. It'll already be abnormal, and it'll be abnormal in the advanced lesion, and it'll be abnormal. So the CT scan of the heart is proving to be the best way to detect early heart atherosclerosis, to teach our patients to wake up and start eating better and exercising. So this is an example of a CT scan from a human. You can see at the very top of the picture, there's the sternum, the breastbone, bones show up white. The ribs are ringing the outside of the chest cavity. The vertebra is the white structure in the back. The lungs are black, and the heart is the gray mass in the middle. And you can see very obviously by the yellow arrow, that is a heart artery that is very heavily calcified. It has that bright white appearance, just like a bone. This is called a heart artery calcium CT scan. And we're looking at a heart artery that's very calcified. This person has a big problem. They've had no symptoms, no shortness of breath. They might even pass a stress test, but in the future, their risk of a heart attack is much, much higher. And they need to adopt every preventive strategy, whether it's lifestyle and maybe it's medication, aspirin, cholesterol medication, blood pressure medication. So some people have had this test, heart artery calcium score. They know that they have no calcium in their arteries. They're youthful. Dr. Sidingham, hypothesis fulfilled. You're as young as your arteries, good news. But if you don't know your heart artery calcium score, you just don't know if you're Winston Churchill and gonna make it to 91, or you're the other gentleman who died at 53. There is another way without the CT scan. You can do an ultrasound of the arteries to the brain, the right carotid artery, the left carotid artery, even in people who haven't had a stroke or a TIA mini stroke. And you can detect, like in this individual, small but nonetheless abnormal plaques in the arteries. That is, again, a sign that there is atherosclerosis and we need to intensify the preventive measures. So,
Kahn, there is a question. Yes. Can we take the question? One question here.
Of course, no problem.
One of Dr. Bindia is asking, is this CT scan is costly, or are you doing CIMT with your patients because it's a non-invasive and cost is quite less?
Yes. So this CT scan test of the heart was developed about 25 years ago or more at universities. A company you probably know of, General Electric, developed a special CT scanner just for this test. And it became a popular test 20 years ago, but very expensive because the CT scanner was a special dedicated CT scanner. That has changed in the last 15 years. Almost any medium-sized or large hospital, and I know it's available in India, I've had many patients have this. In the United States, this test is now $75 to $100. It used to be $1,000 or $1,200. It's very often not covered by insurance, but I've had some patients $49 American. So it's quite affordable for most people. Very often they just pay for it on their own. It takes about 10 seconds. Nothing is injected. It's very low dose radiation. It's equivalent to what a woman is exposed to when a woman gets a mammogram. So it's low dose. And you usually only have this test once, maybe age 45, maybe age 50, maybe age 40 if you're very concerned, but almost never before age 40. The carotid study is a little, particularly this kind, it's called a carotid IMT ultrasound. Little harder to find, maybe at a university. You know, if it's not covered by insurance, it might be a little more expensive, like a couple $100. But really the one that's making the big difference is the CAT scan, because most everybody can afford. Now, in the United States, there are some states, in the state of Texas, Dallas, Texas, Houston, Texas, every citizen can get one of those CT scans for free. It's built into their healthcare law, which is a good thing. And if anybody wants to know more about it, there is a documentary on Netflix about the CT scan called The Widowmaker. It's a very interesting 90-minute documentary, how this test was developed, interviewing some of the scientists and why it isn't used more widely. In my practice, everybody's had one, except if a person's had a bypass or a stent or a heart attack, they don't need this. This is early detection. If you've had a bypass operation, that's not early detection, you know you got a problem. So what do? Why, you know, we want to prevent the disease from ever happening, but we know that that's not really the reality of people walking the streets in Mumbai and New Delhi and Hyderabad and where I live in Detroit. It's just not the case. Lots of people do have heart disease, and they're going to have heart attacks and bypass and stents. So can we stop it if it's already there, and can we reverse it? So I want to go through a little bit, and then we'll take some questions. I'm going to go all the way back to the 1950s, when a very famous scientist in the United States, in Minneapolis, Minnesota, named Dr. ANCEL got interested in diet at a time that it was thought that most heart attacks and strokes were just due to age, old age. But he was interested in nutrition, and he visited Italy in 1951. This is a picture. Dr. ANCEL is holding the piece of paper in his hand, two hands there on the left. He visited Italy, where the professors told him that they almost never saw heart attacks in Italy. He was in Naples, Italy. And he said, that's crazy, because in Minneapolis, we're seeing lots of heart attacks in 1951. And, you know, he spent some time with the professors and came up with a hypothesis that their diet was very different. They smoked a lot in Naples, but their diet was very different. He launched a study that was published in 1970 and then was continued on, called the 7 Countries Study, that looked at many features, but they mainly looked at the content of saturated fat from butter, from lard, from cheese, from meats, from egg yolk, and from ghee and paneer versus the risk of heart deaths. And what they showed, and this is 25 years follow-up, so this was later on. But if you look where it says E is a country with a very high intake of saturated fat in the diet and a very high risk of dying of heart disease. It turns out E was Finland, and Finland had a diet very rich in butter and very rich in sausage. Also, the highest heart attack rate in the Western world. United States wasn't much better. United States was where the A is, very high saturated fat and high heart attack rate. But some countries, like over there on the left where it says T or U, had naturally low saturated fat intake. Either they were not using butter and meats and cheese and you know, other factors in their diet, and their heart disease rate was very low. The other thing he showed was, this is blood cholesterol, that certain countries ran a very high blood cholesterol on average, and where it says Northern Europe, that again was Finland. You can see United States, where in 1970, it was not rare to have a cholesterol of over 300 milligrams per deciliter. I know you guys use a different unit, but the higher the blood cholesterol, the higher was the risk of heart attack over time. So he helped identify that butter, cheese, meats, egg yolks, lard could be important factors in the rate of heart disease through cholesterol. There also is a great example. Finland was aware of their high heart attack rate. There's a region of Finland called North Karelia. And the number of young people having heart attacks in the 1960s was so high that there was a public health project where they started to educate the grocery stores, the wives, the mothers, and the men, It's always harder to teach men anything. But they started using margarine instead of butter, and they started using beans instead of sausages. And within 5 years, you can see it in red, the heart attack rate dropped by 85%. And then the whole country went ahead and adopted this public health message. And the whole country exhibited an 80% drop in dying of heart disease very quickly. And it also spilled over to cutting cancer rates by half and all causes of death by half. So one of the most dramatic public health demonstrations, all published in peer-reviewed medical journals. Another famous study, very simple, was the LYON. This is from France, Lyon, France, diet heart study. Men and women that had had a heart attack, where they had lots of butter in their diet, traditional croissants, French diet, and they were switched from butter, half of them, to a margarine, and many of us would say, God, not margarine, but margarine, high in canola oil. And when they followed these people up for almost 4 years, one switch in their diet, butter to plant-based margarine, the risk of dying in follow-up was 65% lower. They actually stopped the study. This is a very cool, I'm going to shift gears now and move forward. Some scientists actually took patients and asked the question, can we change your diet and keep you alive? One of these is a doctor not very well known by the name of Dr. Lester Morrison in the 1950s. But if you look at this graph, I'm going to show you what he did. But his patients at 12 years, half of them were alive on one diet. None of them were alive with heart disease in the 1950s on a standard diet. And what he did is he gave half of his heart patients this piece of paper. Please avoid eating cream soups, liver, brain, kidneys, whole milk, cheese, egg yolks, pancakes, waffles made with butter and lard, excessive use of fats in chicken and pork fat, bacon fat, rich gravies. Avoid these foods, half of his patients. The other, he let them continue to eat in the 1950s what they were eating in Los Angeles. He published the data. He is a scientist, American Heart Journal, 1951. 100 people that were randomized to this low cholesterol, low fat diet or left alone. They lost weight, they dropped their cholesterol, and you can see the results published of what impact it had on their survival. So Dr. Lester Morrison gave an early clue that we can prevent the death from heart disease, along with the LYON heart trial and others, by changing our diet. The pioneer that gets most credit appropriately is Dr. Dean Ornish, medical doctor in San Francisco, still quite young and active. He was interested in all this research, and he developed more of a lifestyle. Let's introduce to heart patients a whole food diet, low in fat, vegetables, fruits, beans, peas, lentils, whole grains, non-fat cereals, but let's teach them walking, yoga, meditation. He was a student of Satchidananda, and he taught them all meditation for Satchidananda and get them to quit smoking. And he designed a study published in 1990, and then 5-year follow-up was in 1998. He called it Intensive Lifestyle Changes for the Reversal of Coronary Heart Disease. Very prestigious academic authors. These were really high science. And he, in that paper in 1998 was this results graph, which should have changed medicine worldwide dramatically. What this is, it says baseline, 1 year and 5 year. These were serious heart patients that in this research study, this randomized research study, were studied by coronary angiography, heart catheterization, at baseline, 1 year and 5 years, using a computerized method of analyzing the angiogram. And in the black circle is half the people that did not have their diet or lifestyle changed. And the amount of plaque in their arteries got worse and worse. In fact, it was much worse at 5 years out. But what was shown for the first time in those white squares is that people can actually lower the amount of plaque in their arteries. by using a lifestyle that focuses on a whole food plant diet along with yoga and other features. I am sorry, technology sometimes is a pain, but that's all right. There we go. But we can reverse the amount of plaque in arteries through this lifestyle, the Ornish lifestyle program. So this is an example of an angiogram of a severely narrowed left anterior descending artery. 3 years later, when the patient was studied, dramatically better, really remarkable. So I put game over because theoretically, at this point, medicine should have changed dramatically. We should have started teaching in hospitals around the world. Don't smoke, meditate, practice yoga for flexibility and breath and community, walk every day, and eat plant whole food diets. But doctors are slow to change, patients are slow to change, insurance companies are slow to change. In fact, it took about 20 years, but in the United States, a patient who's had a heart attack, a patient who's had a stent or a bypass, can now go to a program called the Ornish Cardiac Rehab Program, or the Pritikin, that's an alternative one, where they learn whole food diets, exercise, and yoga, along with meditation, and it gets paid for by their insurance company. So it's finally happening, but it's taken a very long time, and it's still not widely available. People can buy books and do this on their own, of course. In my practice in Detroit, Michigan, I don't just rely on the science of Dr. Ornish. I actually see it in my own patients using that carotid ultrasound technique. That's widely available, but it's in my office. This is just an example. If you look over in the left carotid, within 1 year, a plaque that measured 4.9 millimeters had shrunk down to 1.5 millimeters. And just below it, a plaque that was 2.3 millimeters had shrunk to 1.1. Change their diet, manage the blood pressure, manage the cholesterol, manage the blood sugar, and a few other tricks that there are out there. This is even somebody, if you look, this is a 67-year-old man that when we first studied his carotids, it said you're 67, but your arteries are like a 75-year-old man. He didn't like that. That's what Dr. Sidingham says. You can tell the age of a person by the age of the arteries. But within just a year of major changes, now it says a 67-year-old man has arteries like a 61-year-old. That's just to say that you can reverse some of the plaque in the arteries through lifestyle. So now there's a yellow arrow showing that this process goes both ways. It can get worse and worse and worse, but we have the potential to influence it to get better and better in time. And just to show you that this is relevant right now, because the studies I was showing you were from the 1950s and 1980s and 90s, not that that means that they're not relevant anymore. This was a major international study published in April of this year, 5,179 heart patients with very serious heart disease. They had angina, their stress tests were bad, and they needed some sort of serious therapy. But they were randomized, it says at the top. They were stable, they could leave the hospital, but they had moderate or severe ischemia on stress tests. These were not minor patients. They had very, very worrisome findings. But what this study did is in the blue box, half of them were put on medication and they did not get an angiogram, they did not get a stent, they did not get bypass surgery. And in the red box, half of them quickly got a catheterization, a stent, and a bypass. So wouldn't you think that a stent and a bypass works better? Well, let's look at what they actually told these patients. They told them to quit smoking, just like every other study out there. They told them to walk 30 minutes a day, 5 times a week. They told them to eat a low saturated fat diet. So goodbye butter, goodbye lard, goodbye most of the cheese, red meat, chicken, turkey, egg yolks. And then they tried to get their blood pressure, blood cholesterol, and other measures at optimal levels. But they followed the same teaching. They did not teach them a completely whole food plant diet. They didn't think that 5,000 people would probably participate in that, but I wish they would have. And when these results were presented, this is the risk of dying over 5 years, whether you quickly went to stents and bypass or whether you got medication and lifestyle advice. And you can see there's no difference, no advantage to rushing to bypass and stents. That medication and lifestyle work, even in these sick patients all over the world. So what do we do as we close up? Back in 2009, a medical society in Washington, D.C. suggested we can get along just fine eating fruits, legumes, grains, and vegetables from the time we're children to the time we're adults. Slowly, this has been increasingly recognized. This is the Harvard School of Public Health 2 years later, where they said, what should the ideal diet be for everybody? Vegetables, fruits, whole grains, healthy protein like beans and peas and lentils, or very lean meats. Don't drink milk, drink water. Don't use butter, lard, or ghee. If you're cooking with oil, use healthy oils like olive or canola oil, and stay active. Many countries have gone ahead and adopted similar findings. This is the country of Canada that last year revised their national recommendations. And you can see they're pretty much aligned. Fruits, vegetables, whole grains, lean proteins that can be completely plant-based, and make water, not milk, your drink of choice. So my dear friend, a cardiologist and a famous administrator at the American College of Cardiology, why does he, a cardiologist, eat plant-based diets? I don't mind dying. I don't want it to be my own fault, however. So we can prevent disease, and we don't want to be guilty of saying, I wish I would have started earlier. I wish I would have made changes long ago. We can start right now to prevent disease and keep ourselves healthy. So that is the good news. I'm going to go back to the Zoom and close this down. And I always welcome any and all questions. And thank you for your attention. And what do we have? We have a few people that have typed in, but thank you. I did put in the notes, my email address and clinic website if anybody later on has a question for me. Somebody quickly said that medical errors is a major cause of death. That's funny. I often include that slide because about 2013, I think it was, at Johns Hopkins University in Baltimore, they did identify that in the United States, their calculations were that the third cause of death after heart and cancer were medical errors, like wrong medication, wrong surgery, allergic reactions, blood transfusion reactions. That number has seemingly dropped a lot because a lot of new policies went into place to avoid mistakes, but it is a rather scary number. So actually, Rahul, you're right, that is published data. I don't know if it's true also in India, but it was published from a US database. When would I request a lipoprotein A level in preventive medicine? The standard statement has been, if your family history, here's that again, lipoprotein A, the heart's quiet killer. If there's a remarkable family history, father died heart attack at 48, grandmother died stroke at 52, check a lipoprotein A. But that is shifting now. Last year, the European Society of Cardiology published recommendations updated that they think everybody should have it done once. And that will probably become the norm in a few years when we get better therapy. I don't know how expensive it would be in your clinic, but in my clinic, it's about $25 or $30 blood test that's usually covered by insurance. And as I said, the CT scan in this area is very inexpensive. Now, there is a question, you guys are asking very, very good questions. You can do the CT scan that I usually order on asymptomatic people, heart, artery, calcium CT scan. There's no IV, there's no dye, there's no allergic reaction. You don't have to have your heart rate super low, inexpensive, and quick. There is a more advanced one where you do get injected with dye, a coronary CT angiogram. And you'll actually see the arteries, or if you've had bypass surgery, you see the bypasses. It's many times more expensive. The radiation is 3 to 4 times more radiation. There is a bit of concern about a reaction to iodine dye in terms of the kidneys or allergies. You have to have a very low and stable heart rate. It's a difficult test in people with atrial fibrillation. And usually it's in the insurance world. It's not a screening test. There are some people, and I have patients that have gone to the Philippines and had that test done for about $300-400, but it's still not generally felt to be a screening test. It's very valuable, and you do sometimes find disease on the CT angiogram that you didn't find on the calcium scoring. So I'm not using it yet routinely. Somebody asked about grains, a good percentage of diet. Yeah, it can vary. There are people that enjoy brown rice and mixed rice, of course, basmati rice. High complex carbohydrate diets are characteristic of all of Asia, certainly Japan. It could be purple potatoes in Okinawa or white rice in Japan, and they've had, traditionally very low disease rates of diabetes and heart disease. It's changing now with McDonald's. So there is no real absolute answer to that. Homocysteine, a question that was on one of the pictures, either it'll be high because you're eating a lot of red meat, because that'll contribute, or homocysteine can be high because you're deficient in B12 and B6, or it may be high because you've inherited genetically a methylation defect. A very high homocysteine level is bad for your arteries, your endothelium. It causes endothelial dysfunction. It's a very easy one to fix by changing the diet and adding in B complex vitamins, which are quite inexpensive. There's a question about the keto diet. I'm just looking through. I could talk for hours about the keto diet, ketogenic diet. It was developed decades ago. They tried to treat children with seizures with water fasting, but it did lower the rate of their seizures, but it's a very difficult way to raise a child, putting them on a water fast. So it was tested to see if a very low carbohydrate, high fat diet producing ketone bodies in the blood would alter their frequency of epilepsy. And for less than half, but for a significant number of the children, it did affect their epilepsy rate positively. There were a lot of side effects reported in those early medical papers. But somehow in the last 10 years, it's just become a popular diet, very similar to the Atkins diet of the 1970s. There's very little long-term research. The short-term research, 8 weeks, 16 weeks, 12 months, and 1 or 2 papers to go out 2 years. There are people losing weight and improving their biomarkers. None of these studies are looking at any vascular status. So it's totally a black box. If you load your plate up with meat and butter and oils, if you're harming your arteries. But there are about 10 epidemiology studies. They're not perfect. Large epidemiology studies that a low-carb diet long-term is associated with an increased risk of death. These are from Greece and Sweden, United States, Japan. I think the most famous is a Japanese author, Noto, in the Annals of Internal Medicine, maybe 2013. So I am not ready to recommend to my patients a ketogenic diet long-term because of this suggestion of a mortality concern, and certainly the absence of any data on what it does to cardiovascular status. So I avoid it. There's a question, should we stop milk altogether? I don't know what access you have. I'm drinking a cup of tea with a little bit of oat milk in it. We have oat milk and soy milk and rice milk and hemp milk and almond milk and every other version. So I do recommend to my patients that they eliminate dairy from their diet. Saturated fat will go down. Cholesterol will go down. They don't have to give up all the joys of life. There is a very famous book that many of you have heard of, the China study by
Yeah.
Colin Campbell, where he doesn't focus as much on the saturated fat, but on the role of the protein in milk, casein, being a cofactor in cancer activation. So there just was a study this week comparing women's soy milk ingestion versus cow milk ingestion. Breast cancer rates went down on soy milk and went up on cow milk. So that's consistent with the studies done long ago that Dr. Colin Campbell did.
There
You
is
might hear a
famous
dog in the
discussion, Dr.
background.
John, in India that vitamin B12 is necessary for our heart and other things, nervous system also. And in
Yeah.
plant-based diet, there is a very less vitamin B12.
Yes. I apologize if you hear a dog in the background. Oh, my wife very kindly took them outside.
No problem. It's a music for us.
No problem. Was there a question in your comment or just a comment? Because the dogs are making noise. I didn't know if there was a question there.
There is a question that because of plant diet, there is deficiency of vitamin B12.
Yeah. I agree with that. Yeah.
So how to compensate? Should we take the supplements or we should choose some food which are rich in vitamin B12?
B12, for those that are eating 100% plant-based, which is what I've done now for more than 40 years, it is possible to deplete your vitamin B12 stores after a couple of years. It's possible worldwide to be deficient in vitamin D. Doesn't really matter whether you're a plant eater or not. There is vitamin D in mushrooms. Some people eat, some don't. Some of the plant milks have vitamin D fortification. You can get vitamin B12 from some foods, but I don't like to put people's health at risk. So I do measure their blood levels of vitamin D, vitamin B12. You also can measure omega-3 fatty acid blood levels, and I do that. And it doesn't matter if my patients are vegan or meat eaters, it's very common to be deficient. So I do supplement most of my patients. There are now some nice little supplements in one capsule, B12, vitamin D, algae omega-3, sometimes a little iodine or selenium. Nice little approaches to it all. But none of these have been studied, but it makes sense to get all the advantages from a whole food plant diet, but don't put yourself at any risk of being B12 deficient. Of course, it's so easy just to check a level. And it is interesting that there are people that have never taken a B12 supplement and they got a B12 level of, very good on a plant diet. Our colon makes B12, but we believe we can't absorb it. Our bacteria make it in our colon because it has to be absorbed in the small intestine, but maybe a few people have some mechanism to absorb it internally.
There is one more question, Dr. Kahn. Dr. Gagan, he is a preventive medicine professor in India. He's asking that you are giving lecture while standing. Is this
yeah, he noticed. I have a standing desk everywhere. I do sit, but about half the day, I don't have a treadmill desk. I might still do that one of these days, but I stand, and it's funny you notice that. I actually also, my wife got me, I'm not sure I like it, but it's a wobbly chair. So while you're working, you have to move around a little bit. Sedentary lifestyle is not very healthy. So any chance, I find lately that if I'm standing during a visit with a patient, they actually enjoy it. I mean, they just drove in their car and they were sitting and they maybe waited in the waiting room for a few minutes. They actually enjoy standing during a visit. At first I thought it was a little rude of me, but when I ask them about it, they find that that's a good example. So if we have a cardiac surgeon, I mean, I used to be in the cath lab standing all day long, but as you move to office practice, you're sitting on your rear end too much. Yeah. There is a question by a cardiac surgeon that he encounters very hard calcium plaques. Can you reverse those lesions? We don't know for sure, and it's a good question. And you're right, when you feel plaque, I mean, it can be like a rock. And from the other perspective, from an angioplasty doctor, putting a balloon or a stent in some of the arteries, it takes unbelievable force to open some of these lesions. Not most are soft, but some of them, we actually, as you know, we have drills to drill through the calcium atherectomy because calcium is hard. It's unclear how much. We know we can remove soft plaque quickly too. I think that's why some of these arteries get better. When you lower the blood pressure, when you lower the blood sugar, when you lower the inflammation, when you lower the LDL cholesterol, maybe lower the lipoprotein A, we know very quickly that softer plaques can start to disappear and shrink. Whether we're actually removing the calcium, there are people discussing a vitamin called vitamin K2, and it affects calcification of blood vessels and also calcification in bones. Whether adding vitamin K2, there are a few foods like natto, a soy-based food or a supplement. There is recently one report of a vitamin of herbs. It's actually gotu kola. You know gotu kola? It's an Indian herb. And another herb called pycnogenol. And in a human research study using these two herbs, the calcium score went down quite a bit. So it may be possible to remove some of the calcification. Others argue the calcification sort of is doing a benefit to the artery by creating a more stable plaque, but I'd rather get the calcium out if we had some way. I don't think there's enough evidence that chelation, intravenous chelation, removes the calcium. That's reported to be the case, but there's really no data at this point.
There is one more question, Dr. Kahn. It is from Alap. Alap is saying that we do heavy anaerobic and aerobic workout like cycling, sprints, running, and long distance cycling, which raises our heart rate up to 90% of maximum heart rate. During the recovery period after the workout, does the body immunity goes down? A few doctor friends suggested to avoid doing such kind of workout during this pandemic.
And the question is, does the immunity go down?
Immunity goes down if you take the heart rate to the maximum, near about 200.
You know, I don't know the answer to that. I don't know if it's known. There are a few people discussing moderate exercise as opposed to extreme exercise right now. There is injury to the body. We know if you run a marathon and we check the blood, you can measure a troponin level that's elevated in a sizable number of the runners, even if they trained appropriately. And you know, and there is inflammation after extreme exercise that you can measure, and maybe we don't want to trigger extreme inflammation right now. So I certainly would never discourage exercise, but maybe moderate is a little better than, you know, extreme. There is some data that ultra athletes, marathon runners, over and over, that they actually may get more calcification in their heart arteries and more atrial fibrillation. So extreme repeated exercise, you know, for some it's very enjoyable, but it may have a slight downside. Yeah. So thank you for your attention. And obviously the takeaways are whole food plant diets, lowering saturated fat, and if the technology is available for you, a little more advanced blood work and early detection. Yeah. Thank you.
Thank you very much, Dr. Kahn. It was really, really very interesting and knowledgeable session. Today, our guests and our doctors have learned a lot from you and about the vegetable diets and plant-based diet. Dr. Saurav.
Thank you very much, Dr. Kahn. I was listening very attentively. And I have watched your many videos. So I was a little bit familiar with your content, but yeah, there were new information, many new insights.
Oh,
yeah.
Thank you very much. Thank you.
Dr. Kahn, there are few informal questions. Can we ask from you?
Yeah, sure.
You are a medical professor also. When you teach your student about the plant-based diet, what are their reactions there in America?
Well,
how they take this plant-based diet?
Yeah, couple answers. When I teach at the medical school during the day, I have to follow the curriculum. And right now the curriculum is teach about blood pressure, teach about diabetes, teach about heart attack.
Yeah.
Usually they ask me, can you come at lunchtime and give us a lecture on plant-based medicine? But it's not on the curriculum because their examination doesn't include questions on nutrition. So I have to sneak in the nutrition information. It's unfortunate, and I hope it will be better. But they're very curious. They know about athletes. They know about soccer players and race car drivers and football players and the rest, and movie stars, and they know all this stuff. And they, now there's more restaurants. Now there's more discussion. So I think the young doctors, many have adopted a vegetarian or vegan diet already. And I think that's very good. Now, not all of them know the data, how therapeutic it can be for certain health conditions, but I'm hopeful it'll be a big change where we use prescription and surgery, but we use nutrition too, like we should.
One more question is there, like Dr. Dean on his study you have discussed with us that medical study should have changed 20 years back, but it's still in that transition phase that we are still working in between, or we are trying something. So how you look about the future of medicine, how you look about the medical study and education in medical schools, sir?
Yeah, what we're trying to get together, it's the same thing as talking about medical students, that unfortunately, the education for medical students, residents, fellows is really based on the examination. And if we can get the examination to focus a little bit on lifestyle, a little bit on nutrition, then they're going to have to teach it everywhere to allow them to pass their board certification. So right now, it's still frustrating. Money is still the king, and the pharmaceutical industry is still much more powerful than this lifestyle discussion we're having. So, that's why we don't know much about lipoprotein A, because there hasn't been a pharmaceutical agent that is driving all the studies. That's starting to change right now. Same thing with homocysteine. When you can treat something with a couple pennies of B vitamins, you're not going to get much research going on. So but I'm very optimistic. I think, the practice of medicine is and the interest in doctors in preventive and lifestyle medicine is much more than it was 10 years ago. Much more.
Totally agree with you. When I was in medical schools near about 20 years back, there was nothing like plant-based diet, exercise. Even in medical college, in our hostel, the lifestyle was quite erratic. We are taking all the things, non-veg, everything. But these days, the students are changing. They're more aware. They're because of internet, because of study, and many students watch your videos, Dr. Dean videos, and other doctors' videos also. Now we can share knowledge also, sir.
I agree. Well, thank you very much, and you all have a wonderful day. Thank you.
Thank you. Thank you very much. Good day, Dr. Kahn. And today we are going to stay. Dr. Kahn is leaving now because he's a busy person. And Dr. Kahn, we are going to do one meditation here. As spiritual doctor, we firmly believe that yoga, meditation, and your mindset can change the disease.
I couldn't agree more. I actually did. I practice something called the 5 Tibetans. It's a yoga flow I do every morning. I actually did that this morning already.
Right, sir. And being a doctor, sir, I follow sound healing and other therapies also in India.
Wonderful.
And Dr. Saurav using acupuncture.
All right. Thank you very much.
Thank you very much, sir. Good day, sir.